Welcome to Collegial Conversations with Diana Clark, the professional webinar series that offers clinical and personal perspectives on issues that are common, but often not talked about. Here is today's Collegial Conversation.
Welcome to Collegial Conversations with Diana Clark. Today we have the pleasure of hosting Dr. Gwilym Roddick, the founder and director of Cognitive Behavioral Therapy of Central and South Florida, PLLC. Dr. Roddick is an expert in CBT and related evidence-based therapies with over a decade of experience. Additionally, he serves as a clinician for the nonprofit Headstrong Project, offering psychotherapy to post 9/11 veterans in both individual and group settings. In this episode, Dr. Roddick and Diana will dive into the topics of how to get help and when to get help when you have a dual diagnosis. Thank you so much for joining us today, Dr. Roddick. I'll pass the conversation over to Diana.
Thank you, Laura, and thank you for joining me today, Gwilym. You and I met in New York City about a decade ago when I think you were based there. Is that correct at one point, or have you always had a dual location with Florida?
No, I unexpectedly relocated here. Well, first of all, thank you for having me.
You're welcome.
And grateful for all your years of advocacy work for the people that we both help, these marginalized and often stigmatized populations, especially. But yeah, no, I was in New York for over 10 years. I went to graduate school there and then I'm a native New Yorker actually, but ended up here during the pandemic and decided to relocate. So it's been a big gift and I'm grateful to bring this kind of therapy, cognitive behavioral therapy and related interventions to Central Florida because we're ranked between 46th and 49th in the state of all the 50 states in mental health services.
In Florida, that is shocking. That's stark right now. Yeah.
In New York, you have several CBT, acceptance and commitment therapy, OCD-based group practices. In my area of Central Florida, there are two, and that's including my own. So it's very needed.
Talk about the importance of a CBT practice. Who does it serve, and where would you make the recommendation that this would be a good modality?
It's a great question. So I specifically help people with anxiety disorders and also have a niche in helping people with co-occurring substance use disorders and treating them concurrently if possible. Most providers have sort of a single focus, and that's fantastic. You know, they're really good at what they do. But when it often comes up with substance use, you kind of have these two worlds. You have the treatment center world, the 12-step world, the residential program and IOP world, and then you have individual practitioners who usually either refer people to these places or see them when they come out. Now, there are very few evidence-based providers and even evidence-based treatment centers that help people with things like OCD or do real CBT therapy or exposure and response prevention while someone's in treatment. And oftentimes people don't even need residential treatment, even though a lot of people assume that they do or their family members might. They need to see potentially a psychiatrist, a really good therapist, potentially some sort of group component. So a lot of people come to see me and I guide them to the right resources, the specific level of care. But I would say, you know, I have a bias in being an evidence-based practitioner that things like cognitive behavioral therapy, exposure and response prevention, acceptance and commitment therapy, motivational interviewing are the ways I think people with a lot of conditions should receive help.
Got it. So what is the difference? I'm going to ask a really ignorant question. What's the difference between CBT and ACT, acceptance and commitment therapy? I've been curious, so I'm going to plumb your brain right now. Yeah.
Oh, no, it's a great question. And oftentimes people want to know the nuances. So years ago, when Beck and Albert Ellis started rational emotive behavior therapy and cognitive therapy, they really focused on the thinking. And then there were behaviorists who said, oh, it's very much focused on the behavior. And then they said you couldn't have one without the other. So it became cognitive and behavioral therapy. And then Marcia Linehan, who developed dialectical behavior therapy, Steve Hayes, who developed acceptance and commitment therapy, and the mindfulness-based cognitive therapy researchers and practitioners were what we call the third wave. So the first was focused on the thoughts and the behaviors separately. Then they sort of joined forces. And then now we're adding the third wave, which incorporates mindfulness techniques. So years ago, we used to focus a lot on getting people to essentially maybe eliminate their phobia or eliminate their OCD. But then they realized after a lot of research that it wasn't fully going to go away, or that people were coming back and saying, I relapsed, I slipped, I started doing these things again. Maybe they felt like they were failing. They weren't. What we needed to focus on was enduring the challenges that are going to come up when they get stressed again, or that these things never fully go away. So ACT, DBT, mindfulness-based interventions allow people to become more accepting of themselves and also not focus on symptom reduction, which is a huge thing that relates to not only things like OCD, but also substance use. We want people to feel bad and tolerate it versus trying to get rid of it.
Interesting, which is really different from the traditional therapy for particularly substance use disorders, which is get rid of the behavior and then deal with the feelings, right?
Right.
So
well,
how does that differ? Yes.
Well, I would say that you definitely want to eliminate some behaviors so you have leverage to make a different behavioral choice. If someone's doing something 90% of the time, right, and 10% of the time they try to do something differently, the likelihood is not there that they would do that different step. But if we gain some leverage, if they give up 50, 60% of what they're doing, they have an opportunity to build up distress tolerance to then make a different choice. And then we just need to teach people how to make those different choices and what those choices are going to be most helpful for them.
So it is letting them in some ways be the author of what works for them more
Correct.
than this is what needs to work for you.
Correct. So in CBT for anxiety disorders, let's say, or ACT, we call it ACT as opposed to ACTs because it's a very behavioral intervention and not focused so much on the cognitive. So it's about the doing versus the thinking. So you just do. I often have my clients put up a sign like the Nike logo above their desk that says, just do it. Just do it. Don't think. I'll take a step back. So in CBT interventions for anxiety disorders, let's say, we focus on patterns of avoidance, certain patterns of thinking, which lead people to certain behaviors, which temporarily relieve their distress, but in the long term, make them so susceptible to those thoughts and feelings that they have to act upon them. So with things like hand washing or even using substances, certain mental rituals, food, right. Exercise, all those things are very interrelated. They're just patterns of avoidance. And they're patterns of avoidance from an ACT perspective of the things we have labeled in our society as undesirable or unwanted or things we shouldn't experience. Like we shouldn't experience imperfection. We shouldn't experience boredom. We shouldn't experience doubt. CBT is called, it's not CBT, OCD is called the doubting disorder, right? So if there's some sort of ambiguity, people try and find certainty. And what we try to do is teach people to tolerate those things versus getting rid of them. So in essence, we expose people to these certain distressing situations to have a corrective experience. And then we allow the new learning to kick in. Them see that something bad hasn't happened, or that the feeling and thoughts did pass, or that, even if something bad is happening, they can deal with it without reverting to something that's unhelpful.
So skill building, confidence building, and distress tolerance all at the same time, right?
That's right. And, with these patterns of avoidance that, many of my peers and I, for example, would love to throw out the DSM because from our perspective, they're all just patterns of avoidance. A person dealing with schizophrenia is trying to neutralize their distressing delusions, hallucinations, thoughts, and feelings, right? And they may take X, Y, and Z behaviors. It's great that we have these diagnoses so we can research them and give legitimacy to people's suffering. But in essence, most people have multiple issues, right? So, and that brings me to my other point, which is like, 25% of people with OCD have a co-occurring substance use disorder, and only 10% of people with OCD get evidence-based treatment. So there's a huge gap in terms of people getting the help that is most helpful to them. What I also do in my work with people is educate people about how certain interventions can be limiting or actually counterproductive to what they're trying to do. So for example, a lot of people go to substance use treatment or 12-step program, and they're taught, when you experience this thought or feeling, you should do this behavior. Now, sometimes those behaviors can reinforce someone's obsessive compulsive disorder.
The ritual. Yeah.
The ritual. So, and people go, for example, to multiple meetings a day, or they pray multiple times, or they call 10 people because they're trying to get out of how they feel. Now, I think it's good to utilize some of those tools to develop a good support system to, if that's what you need to do, that's actually what you need to do at that moment or that period of time to get through drug and alcohol cravings, or just to use, or just I don't know, explode on your boss, you know, or you're having a bad day and you want to yell at somebody or break something. But I do think those things can exacerbate people's OCD rituals. And if a person's not aware that that is happening at the same time, which most AA sponsors and peers are not, then they could unintentionally be reinforcing someone's OCD symptoms.
So, which brings me to another question. When I first went to graduate school a long time ago, there was substance use treatment track, and then there was the mental health track, as if they weren't interrelated. How did that develop? Do you know, or why did it exist? Yeah.
It's a great question. And, you know, I've actually done some research on this. So when I was in graduate school, the courses for substance use were electives. They weren't even mandatory.
That's right.
And when I've talked to psychiatry peers of mine, the rotation was maybe a month, maybe 6 weeks, even though it's such a common problem, right? So I think it started years ago with the fact that there was a heavy stigma related to substance use disorders. And when the peer support model came about, they were like, well, we take care of our own, right? We can do this ourselves. We can do this together because the doctors don't understand us. The therapists don't understand us. And this seems to be working, or working well enough, right? So, and still today, I find practitioners, and again, if there's only a couple treatment centers that'll help people with OCD and substance use concurrently, or help someone with an eating disorder and substance use concurrently, right? So there's still not enough acceptance that the provider can do both, and enough training that they can do both, but also that these things are interrelated. You don't need to treat necessarily the addiction first. You can do it at the same time in many cases. But I think it came from this stigma and separation. And then over time, the treatment center world is just, and the 12-step world has been very on one side, and the therapeutic world's been on the other. Though, you know, there's been a lot of helpful information and research from like the CBT practitioners over the years about how they help people with substance use, and the acceptance and commitment therapy folks too. There's a great workbook called Wisdom to Know the Difference by Kelly Wilson, and it takes people through that process. And when I actually discovered ACT, I said, oh my goodness, this is a lot like the themes and principles of a 12-step program, just nuanced and worded differently.
And not shaming. I'm not saying that the principles are shaming in and of themselves at 12-step meetings, but for people who are not capable of ascribing to the full 12-step philosophy can often find themselves shamed.
Yeah, I say to people, how would you like to identify? You know, are you a person that's just, you know, in my mind, all the diagnoses are just forms of suffering. So you're a person that's suffering. These are the specific ways you suffer. What are some more helpful ways to deal with those problems, right? You know, addict, OCD, PTSD, they're all culturally and contextually created names, and labels, and they will change over time. PTSD was Vietnam War veteran syndrome, and shell shock before that. And, years ago, everybody was schizophrenic, and then everyone was bipolar. Now everyone has ADHD. It's just like, and there's so much overlap in terms of what people experience. So even in the evidence-based world, we're moving towards more of a transdiagnostic model, something called the unified protocol, which takes elements. It takes elements of different interventions that we know that work. For example, exposure therapy, which we know works for anxiety disorders of all kinds, also works for trauma. We take mindfulness techniques, we take cognitive restructuring, and kind of say, well, what's going to be most helpful to the person right now? I'll give you an example. A person with OCD who ruminates a lot and tries to find certainty through health anxiety issues, hypochondriacal issues, worried about being sick or having cancer, a certain disease. They go to a lot of different doctors. They Google a lot. They get a lot of tests. They probably aren't served by cognitive restructuring, because that's what they've been trying to do, is seek a certain thought or certain evidence that they will be okay. What we try to do in that situation is try to get people to accept that distress, not mess with it, not seek reassurance, not act on those things, give up a lot of those reassurance seeking and safety seeking behaviors, and learn to just, they could be sick, or they've gotten enough information that they're not, and now they just need to be with that experience, even though there may be some truth to it. So cognitive restructuring wouldn't help in that situation, but mindfulness techniques would. Exposure therapy techniques would. Later on, though, I've seen in working with people with OCD, or what we've labeled as OCD, is people being able to use cognitive restructuring. Just maybe not immediately. Maybe they can use it after they've developed such a tolerance for what they experience. They don't act on those things, but maybe they're having a rough day at work and they're feeling low about their self-esteem, and cognitive restructuring is a great tool to challenge the evidence that a person's a failure, for example, or that they're not doing well in their life, or that they won't do well in their life and they'll always feel this way. If you said, well, let's look at that, then they go, oh yeah, I guess I won't always feel that way, or there are a lot of people who care about me, or I've managed to do a lot of successful things. So that may not work for someone, though, who's in the thick of rumination and obsession and rituals. They just would say that doesn't resonate with me.
And there has to be sort of space for new input. If your brain, I'm speaking as a pedestrian right now, just like if your brain is spinning and there's no room for other thought, how do we even get inroads on that without actually arresting some of the behavior, right?
Right. So it's more about what's going to work for this person, right? And so as opposed to, people often criticize evidence-based interventions as manualized. The manual is there so we could look at variables and certain aspects of what a person experiences and see if we can find out what's going to be helpful, right? But most of us don't use a manual on a daily basis. We work with a person. And if we did use a manual, we probably wouldn't help anybody, because we'd be very frustrated that the manual wasn't perfect.
It's not working. Right.
It's not working. And I've helped a lot of clinicians who I've mentored say, it's a lot more nuanced than that. Or, let's kind of start here versus starting there, because I don't think they're ready for that.
That's the art of what you do. That might be the workbooks, the rubric might be the science of it. But the art is when, how, and in what way, right?
Exactly. And I think the unified protocol and this sort of transdiagnostic model of there are variables there are elements of what we do that helps people. Where can we kind of get in there? Look at it as, you're climbing up a mountain, it's not a straight line. So how are we going to get the person still moving forward, right?
Right.
So I think there's a lot to be, I think there's a lot we could be doing as evidence-based practitioners to help people with substance use disorders specifically. I think I even have given talks, titled things like, you already know how to do this, because I think if you know how to do OCD work, you probably could learn how to do substance use work but because of stigma, because of lack of exposure, because there's nuances to it. And I'm not saying everybody should feel comfortable working with everybody. There are definitely people who specialize in working with certain populations that feel very comfortable, and those are the people who should be working. But because substance use comes up so often, and for many, many people, it is not going to be helpful for them to jump to a residential treatment program. They wouldn't be open to a 12-step program or an IOP, which, by the way, 12-step is one of the best support systems out there for people.
Sure.
It's free, it's accessible, it helps millions of people. I endorse it as an option to recommend to people. I say I haven't found another support system that's that easily accessible and where people are going to help you for any other issue I've worked with.
Me either.
Maybe the veterans I've worked with who say they'll always be there for a fellow veteran, but that's about it.
Mm-hmm.
There's no bipolar support group, there's nothing out there for these things. So I feel it's a great option, and people can also find their way in it. They can find the things in the program that are most helpful for them.
But it isn't the end in and of itself for many people who are struggling with co-occurring issues.
Yeah, and what I often say to people if they come to me and they said, do I need to go to rehab, or they've been assigned to me by a family member or a loved one, I say, well, let's get a very clear assessment about what's going on. Maybe not just from me, but also from a psychiatrist.
Right.
Then
like
we
data.
know.
Right.
Yeah, let's get the data. Let's get the information. Okay,
That's
I see
right.
some traits of this, some traits of that, this is influenced in your life, or you told me when you were a kid, you used to pray a lot and do sort of counting rituals to make sure that your parents didn't die in the night. Okay, that's a trait of OCD. What else are you doing right now? Okay, you have OCD, but differently right now. Okay, what else is going on? Then there's a lot of substance use. Then we say, okay, well, here are your options. You can go X, Y, Z. What are you willing to try? And work people towards, getting the most help that they can get.
Great. So what didn't I ask you? What else would you like people to know before we close up today?
I think just that it's a very, working with people, particularly with OCD and other anxiety disorders with co-occurring substance use disorders, is a very under-researched area. We need a lot more attention paid to this, and we need a lot more treatment centers to train their providers on how to do these interventions. They're not super complicated, there are ways that people can learn how to do this. I would also say that there are a lot of great people out there doing amazing work, and we can always just do better. And I think even if you don't know what provider to see, if you see a CBT or ACT or ERP therapist, you'll probably get a pretty good assessment of what the most research-based interventions are out there, and that can guide you to sort of the next step. They may not know about lots of other aspects, or even maybe not like the best treatment center to send you to for substance use, but they do know a lot about sort of what the research points to. And I think that's very helpful to give people those options.
It's data.
It's very good data.
Data make decisions, and that's data. Yeah.
Absolutely. Absolutely.
Well, thank you, Dr. Roddick. I appreciate you taking the time. And I look forward to actually watching this when I can digest what you said today. Thank you.
Excellent. Well, I'm so glad it was helpful, and thank you again for having me. I appreciate the opportunity to speak about this.
Thank you for joining this webinar. Tune in to more webinars and sign up for our newsletter at o'connorpg.com.